Welcome back. Now that we've seen a look at the inspiratory and expiratory process itself, we can take a look at the actual movement of gases in and out of the lungs themselves. So we talked about being able to change the amount of pressure that is inside the intrapulmonary, intrapleural, and dealing with that with the atmospheric pressure, and allowing for air to move into the lungs. Now, we have one thing that we kind of talked about in the vascular system, in that we had a process where we had flow and we also had resistance. So there we talked about peripheral resistance. Here we're going to talk about resistance in the airways as well. And this is going to play a role when it comes to the amount of air that can move in and out of the lungs themselves. So although it doesn't really seem like it, there is friction when air is coming through the airways themselves. And so through our conducting zones and down into the respiratory zones, we do have resistance. And that plays a role in terms of the amount of airflow that we actually have. So our airflow is equal to the change in pressure over the resistance that is there. And so the amount of resistance that we have, so flow equals change in pressure over resistance. And so that change in pressure that we have, that's our difference between our atmospheric pressure. So this way may just be simply 1 millimeter of mercury pressure over the amount of resistance that's in the airways themselves. That resistance is going to be similar to what we had in blood vessels as well, where we can change the diameter of the airways. And so if we have more constriction that's there, that's going to lead to an increase in friction, an increase in resistance in the airways themselves. That change in diameter can also be just simply from things like mucus being on the inside of the airways themselves. And so we can have that, as well as bronchoconstriction, where the airways themselves actually constrict down due to the smooth muscle work that is there as well. When we're in a fight or flight state, so if we have sympathetic nervous system or the epinephrine coming from the adrenal glands, we have the potential here where normally when we talked about it under the cardiovascular system, we talked about it as far as vasoconstriction. Here we're going to have it as being a bronchodilation. So it's going to cause the bronchioles to actually dilate and increase in size when we have epinephrine present. So it's going to go the opposite direction that's there. And so lots of different things can cause that resistance to occur inside the airways themselves. One of which we talked a little bit about before was the alveoli. And so inside the alveoli, just like with all the rest of the respiratory tract itself, we have fluid. So there's a small amount of fluid that's lining the inside of those airways. And so here we have our alveolus that is there. Actually, let's make the alveolus itself green. And then the blue is the water. And as that alveolus becomes smaller as we exhale, the water gets closer and closer. And that water is then going to start to become attracted to itself. And so some of the properties of water is its adhesion properties. And so it's going to want to draw itself in. So it's going to want to essentially collapse those alveoli. In order to reduce the potential that that's going to occur, we have a substance that's produced by our cells in the alveoli, our type 2 cells. This is surfactant. And so surfactant gets produced in order to reduce the surface tension that's there. So surfactant reduces the surface tension. This is going to make it so that the water, in a sense, isn't as attracted to itself. This is the same principle as you've seen commercials of like soap in a greasy sink, and they put a little bit of soap in there, and then all of a sudden all the grease starts to fall to the bottom and things like that. Well, same principle. We're reducing the surface tension that's there. Surface tension is also what allows things like bugs and things like that to skim across the top of a pond. They haven't broken the surface tension that's there, or like a leaf to float on the top of the pond itself as well. So if we don't break that surface tension that's there, then things don't fall through. when it comes to our lungs, if we have a high surface tension that's there, then we're going to have more and more tug, in a sense, by the water to try and collapse those alveoli down. So surfactant is an important aspect of that process of maintaining the integrity of our airway. The lungs themselves, we talked about before, when it comes to inflating the lungs, it's kind of like blowing up a balloon. And so the lungs themselves do have a resistance to expansion. And so their lung compliance that is there is essentially how easily do they expand. And so how well or how with what ease are the lungs able to become expanded when we breathe in. And so the volume that is there between an individual lung when it is, in a sense, deflated versus the volume of the lung when it is inflated is going to be that kind of measure of the compliance that is there. How much distensibility, how much stretch do the lungs themselves have that is in there. And that's going to be a component of all those little alveoli as well. How hard is it to get those alveoli to open up? I was making little dots on this side. So how easy is it for us to open those up? How easy is it for the lungs themselves to inflate? And also, what is the surroundings of the lung like? And so are there problems with the thoracic cage? Are there problems with the ribs that's there? Is there problems with the thoracic vertebrae? All of those have a potential to change the compliance of the lungs themselves. And so things like deformities of the thorax, and so things like scoliosis or kyphosis have that potential there. The costal cartilage that can ossify over time with age and different diseases, and so that can decrease that compliance that's there as well. The intercostal muscles, if they've become paralyzed in any way, if we have a broken rib, things like that, all of that can change that compliance that's there. Back to the inside of the lungs, we have things like our surfactant. So if we have reduced amounts of surfactant, this is a common consequence of a premature baby. And so surfactant itself doesn't actually get made until kind of the last portion of pregnancy itself. And so typically around 29 weeks is a fairly safe time for delivery. And after that point, typically surfactant production is going to be pretty well pronounced. Before that point, you get down into 27 weeks, 25 weeks, things like that. And the amount of surfactant that's being produced can be quite minimal. And so they're going to be more prone to atelectasis or lung collapse that's there. And that's going to reduce that ability of them to expand as well. Other things like fibrosis or scar tissue after different diseases can change the resiliency of the lungs, the compliance of the lungs themselves. The smaller airways, the more fluid that we get inside, so more mucus or fluid that is inside the lungs from something like pneumonia or CHF in terms of heart disease, and we're getting fluid back up into the lungs themselves, all of this can make it more difficult for those lungs to expand. So when it comes to the lungs expanding themselves, one of the things that we want to be able to do is understand whether the lungs are inflating normally as well as deflating normally. So are we having a normal inspiration and normal expiration process in a person's lungs? And so we use a respirometer in order to measure this process. And so we're going to talk about all of these different respiratory volumes here. And so we'll go through and see it on a chart here. I'm just going to fast forward to that chart or the graph itself that's there. So we'll look at the tidal volume, the inspiratory reserve volume, our expiratory reserve volume, our residual volume, our inspiratory capacity, how much can we actually inflate the lungs completely, how much do we have after we expire, so our functional residual capacity, our vital capacity, and then our total lung volume itself. So we'll start with essentially the total lung capacity. And so this is as we breathe in. So a respirometer looks at our ability to move air in and out. And so you'd have like a nose plug on and then a mouthpiece, and you're going to breathe through your mouth and get the air to come in as much as possible. So if we were to completely deflate a lung that had been inspired completely, we would have a rough capacity of around 6 liters. And so that's going to be the amount that the lungs are completely there, but that also takes into account what we call the residual volume. And so the residual volume is, even after we breathe everything out that we physically can, we still have some air inside the lungs. And so the lungs themselves are always, in a sense, primed. They always have some volume in there to keep things inflated. Otherwise, all those alveoli would start to collapse. The entire amount of air that we can actually move is what we call the vital capacity. And so the vital capacity is take your deepest breath in and then blow it all out as much as you can, get all of the air out. That is our vital capacity. That's the total amount of air that we can actually exchange in one breath. So full breath in, full breath out, that is our vital capacity that we have. And that's about 4.8 liters in total. From there we have kind of our normal breathing process. This is what we call our tidal volume. So the tidal volume is our normal inspiratory, expiratory process. This is roughly 500 milliliters. And so we have half a liter or so with each breath going in and out. And so that leaves a large amount of inspiratory reserve as well as expiratory reserve. So we have two sides of that. So if we were to take and have, so here we have our normal, our starting on our read here, at this point here, we take a normal breath in, we take a normal breath out, and then after that normal breath out, we take a full maximum inspiration. This is going to be our inspiratory capacity. So this is the amount of air after a normal expiration, the amount of air that we can get back into the lungs. And so that's going to combine the tidal volume plus the inspiratory reserve. And then after we take that full inspiration, we do a full expiration, and it comes all the way down to everything that we can get out. We've now done our vital capacity. So vital capacity is a combination of our tidal volume plus our inspiratory reserve volume plus our expiratory reserve volume. So we have a couple of different parts there. Our inspiratory capacity is tidal volume plus our inspiratory reserve volume on there. So, and then we come back up to a normal rhythm, and we have just our tidal volume occurring there as well. From our normal expiration to complete emptying of the lungs themselves, this is our functional residual capacity. And so this is the amount of air that we still have left in the lungs that could be gotten rid of after we have a normal expiration on there. And so different types of volumes, we can use this information to get us information about how well does a person breathe in, how well does a person breathe out with different types of diseases. And so are they able to get rid of all of the air that they breathe in? Are they able to get rid of or to breathe in as much as they could, things like that, and use that test to essentially look and see how the disease may be progressing and so on. So that amount of air that we just looked at was measured at the mouth. But the thing when we're doing this spirometer that's there is that we're looking at the amount of air that came in at the mouth rather than what's actually in the lungs. And so this test itself is going to end up giving us an amount of dead space. And so the dead space is anatomical dead space goes from that beginning point at the mouth and the nose all the way down to the respiratory zone. So all of our conducting zone is anatomical dead space. We can also have dead space that is there from disease, and so we can have alveolar dead space where the alveoli just aren't functional anymore. And this is where the spirometer and the spirometry comes into play in order to actually be able to measure these processes. So a couple of different ways that you can do it. Essentially, you breathe into a chamber that has an inverted bell inside of water. So we have a essentially a big bucket, and then on that bucket we've got water, and then floating in the water we have a bell, and that bell is then connected to by a hose, which you then breathe in and out of. And so this bell is essentially going to go up and down based upon whether we breathe in or out. And so then we can measure it and decide whether we have any kind of obstruction of the normal airflow that is there. When we look at respirations, typically most people are going to think about just simply how many respirations are there per minute. So what's the frequency that we have? And so this is similar to that of the heart rate in a sense. So this is our breathing rate as far as our frequency goes. But we also have to look at essentially how much air did we actually move in. So we have our tidal volume minus our dead space, because the dead space isn't actually going to be able to be used in the exchange of gases themselves. And that's going to get our alveolar ventilation rate. And so this is how much air is actually going to be able to be exchanged within the lungs themselves. That's there. Depending upon how we change our respirations, this is going to alter our alveolar respiration rate. And so if we take deep, slow breaths, our AVR increases. If we take rapid, shallow breaths, our AVR decreases. And so we're going to change that amount there. So if we took deep, fast breaths, we'd increase our AVR even more. When we move air in and out of the lungs, we don't always do so in a sense with an intent for respiration. And so we have these non-respiratory air movements that are there, most of which are essentially a reflex. So things like coughing, sneezing, hiccuping are all things that we can't control. Same thing with yawning. To a certain degree, we can't really control crying or laughing as well. But in general, all of these are going to decrease our ability to breathe on a regular basis. And so they're going to change our output at any given time for our respirations. When we look at that air that's come in, so we said that we have air coming in at the mouth and the nose when we're doing the spirometry there. Those changes that are there are going to be able to be looked at as far as that mixing of the gases themselves. And so we have dead space in the lungs, and then we also have our reserves. And so since we don't expire all gases every time that we breathe in, the air that comes into the actual lungs themselves is a mixture of all of those combinations that are there. And so when we look at the changes that are there from the atmosphere, we see that we have some alterations of the overall concentrations of different gases inside the lungs themselves. And so when it comes to air, just kind of atmospheric air, we have lots and lots of nitrogen, we have lots and lots of oxygen, and very little carbon dioxide. So very, very small amounts of carbon dioxide. But our body is getting rid of carbon dioxide, so when we get into the lungs, our carbon dioxide levels are going to rise pretty tremendously. And then same thing, our oxygen levels and our nitrogen levels are going to go down quite a bit as well. So all of that is mixing with air that's already in the lungs with air that is inside the atmosphere. So external respiration is going to be that part where we actually exchange gases at the lungs themselves. So between the alveoli and the capillaries, this is where we're doing this process. And it's going to follow along essentially concentration gradients. But for gases, we call them partial pressures. So again, I take you back to the picture that I drew before where we had our ground, and then we have our column of air that is there. And inside that column of air, we have all of our mixture of different types of gases that we have inside there. And it gets to the point where there's just tiny, tiny, tiny bits of each different kind in there. And that partial pressure, so if this is, in a sense, one atmosphere, is what we have there, or say we go back to a little bit easier to divide up, 760 millimeters of mercury in our column there. each portion of our gases takes up a subset of that. And so things like our oxygen, our CO2 are going to be a percentage of that 760 millimeters of mercury that's there. And so we're going to have to be able to take that gradient from between our alveolus and our capillary that's coming by that alveolus there, and essentially match the amount of air that's coming in with the amount of perfusion or blood flow that's going through there. And so we need to match our alveolar ventilation with the pulmonary blood perfusion itself, and that's going to allow us to get the right amount of mixture of oxygen coming in. So the PO2, or the partial pressure of oxygen, and the PCO2, the partial pressure of CO2, are the two major gases in a sense that we're concerned with the majority of the time. And so our PO2 is going to be different between the alveoli and that of the capillaries. And so in the bloodstream, we have a venous PO2 of approximately 40 millimeters of mercury. But inside the alveoli, we have a PO2 of approximately 104. So we have a pretty good gradient here. And so we've got a pretty steep gradient between the difference between pressures inside the alveolus and that of which is inside the capillary that's running right next to it. And so this is going to allow us to move oxygen into the capillaries at a pretty swift rate. And so as blood is moving along the inside of this capillary here, it only takes about a quarter of a second for it to become completely saturated. And so this allows for the blood to be quickly saturated inside there as it's moving along. We can get up to 100% saturation without really having to change our normal kind of restful breathing or cardiac pace at all once it's inside there. So when we look at the PO2, in this particular picture, we have a PO2 of 105 inside the alveoli, and then our PO2 in the capillaries down here, it is 40. And so it's over here as 40 millimeters of mercury. So we have that still steep movement, so oxygen is going to very easily come into the inside of the capillaries. Once it gets inside, again, it's mixing with blood coming back from the lungs themselves. And so leaving the heart, that PO2 is going to be approximately a little bit less. So it's going to be around 100 millimeters of mercury on its way out. CO2 is going to have a similar type of a change in the pressures that are there. And so the thing is, though, with carbon dioxide is much more easily dissolved inside the blood, so we can have a much smaller gradient between the two sides. So for PCO2, our PCO2 in the alveoli is 40 millimeters of mercury, but in the blood coming into the capillaries, it's only at 45. So we've only got a 5 millimeter of mercury difference between the capillaries and that of the alveolus. So that steeper gradient, that ease with which we can get rid of CO2, means that we don't have to have such a great gradient. We're going to be able to blow off that CO2. If this CO2 level goes up just a little bit, that gradient becomes even greater, and even more CO2 gets blown off into the alveoli themselves. And so we lose even more as it's coming out there. This one here also shows us that the air coming in, when it comes to our CO2 and O2 levels, the PO2 of the inspired air in this particular case is at 160 millimeters of mercury. But by the time that we get into the lungs, it's only at 104. And the more dramatic of the two is that PCO2 is at 0.3 of a millimeter of mercury. But by the time that we get into the lungs, mixing with all of that stale air that's inside there, we have 40 millimeters of mercury. So tremendous amount of difference as that air mixes into the lungs themselves. Once we get to the tissues, the process just simply reverses. And so now we have a high PO2 inside the capillaries. So we're at that 104 millimeters of mercury. The tissues have only 40 millimeters of mercury, and so oxygen quickly unloads from the blood and into the tissues themselves. And the reverse is the same for the CO2. We have blood coming into the capillaries at 40 millimeters of mercury. In the tissues, it's 45 millimeters of mercury or greater, depending upon the tissue's work at that time. And so if that tissue is doing more and more work, that CO2 level may be even higher, and it's going to drive more of that CO2 out of the tissues and into the capillaries to make their way back to the lungs. So this goes back to the idea that it only takes a very short amount of time in terms of perfusion to allow for oxygen to become completely saturated into the capillaries themselves. And so we go down from our 40 millimeters of mercury up to our 104, 105 millimeters of mercury in just a quarter second there, leaving a plenty of time for, even if our perfusion was greater, still plenty of time for us to be able to pick up all the oxygen that we need. One of the key things that is happening inside the alveoli and the capillaries to allow for this very quick movement of gases between the two is the fact that our respiratory membrane is very, very thin. And so we're talking about 1 micrometer at its thickest. And so anywhere from a half of a micrometer to a micrometer in terms of its total thickness. This allows for that gas to move very, very quickly and very, very easily in between the two layers that are there. Combine that with the fact that we have a surface area inside the lungs of somewhere in the neighborhood of 60 square meters. This is just a huge amount of space. And so we have a very large amount of surface area there to be able to look at as far as that exchange goes. So if we have a situation where more fluid is coming into the lungs, and so we've got more mucus build up inside the lungs, or we've got actual fluid build up in the lungs from things like infection, so things like pneumonia, CHF, emphysema decreases the surface area that's there. Infection causes more mucus to be developed, things like that there within there. All of that basically thickens those walls. And so if we have our wall here and we add a whole bunch of extra mucus onto that component there, that means that in order to get our air to move into that capillary, it's got to now move through the mucus and then the walls themselves in order to get there. When it comes to things like emphysema, where our normal kind of, and we'll look at emphysema later on towards the end of this chapter. So here we would have, in a sense, kind of normal alveolar sac. With emphysema, those alveolar sacs become, in a sense, larger. And so it's more so not that they've become larger, but that some of them have become broken, and the amount of surface area that we have declines. And with that, we'll pick up next time on our lungs and start to look more into the